coronary syndrome. Syndrome is a constellation of many disease under one roof and then become a syndrome. Okay. Can you next slide? Okay. So in this topic, we will discuss about how to diagnose unstable angina, non-STEMI, and STEMI. Yeah. Because in acute coronary syndrome, actually it's divided into two groups. Number one, we call it unstable angina and non-STEMI. Another group is STEMI, some say STEMI, ST elevation myocardial infarction. Okay. Then if you talk about the myocardial infarction, actually, there will be two types. Actually, we discussed type 1 versus type 2.
Recording in progress.
Okay, the type 1 actually basically is because of we know the pathophysiology, the cause is within the blood vessel. The type 2 myocardial infarction normally is secondary to the cause, for example, like anemia, sepsis, kind of thing, spasm. That also can cause features like in acute myocardial infarction. So the next we will discuss about STEMI equivalent. And then briefly, probably we will discuss about the treatment in the emergency setting. Next. Okay. Actually, very important for us actually to differentiate between stable angina and acute coronary syndrome. What is stable angina? What is acute coronary syndrome? Actually, it is two different disease, two different pathology, even though the clinical features is the same. Why I say it is the same? Because both, yeah, if you have stable angina or unstable angina, STEMI, acute coronary syndrome, both actually presents with chest pain. So, but the pathophysiology actually is different. Yeah, in stable angina, the pathophysiology is due to the atherosclerosis. Yeah, the blood vessel, yeah, but getting thicker and thicker because the atheroma, yeah, then getting thicker and thicker. Even, for example, like they totally occlude the blood vessel 100%, but the patient still has stable angina, which won't kill the patient. It's just the patient present with chest pain. I think up to now you understand, yeah? Hello?
Yes.
Okay. The second thing is we are talking about acute coronary syndrome. Acute coronary syndrome is not because of it is because of the atheroma, but the cap that cover the atherosclerosis, the cap that cover the sepsis is thin or get ruptured. You know, when the cap get ruptured, it stimulates the clotting mechanism cascade and eventually occlude the blood vessel. Okay, yeah. So the presentation of unstable angina and non-STEMI and STEMI, it depends on the degree of the blockage and the speed of the blockage, yeah. For example, like in the STEMI, ST elevation MI, the clotting mechanism occurs actually very fast and totally occlude the blood vessel, which gives to symptoms, cardiac enzyme, and also ECG changes. With in the unstable angina and non-STEMI, it depends on the speed of the blockade. Yeah. If the speed of the blockade is in unstable angina and non-STEMI, basically it won't occlude 100% the blood vessel. But because of the speed, meaning that because of the speed very fast, if the clotting mechanism occur too fast enough to give myocardial necrosis, the patient will present with non-STEMI. But if the speed and the degree of the block is not severe enough, and yeah, the patient will present with unstable angina. Okay, I think you can see from the diagram, the cartoon here in the lumen, this is the atherosclerosis atheroma. In stable angina, this atheroma getting the atherosclerosis getting thicker and thicker and thicker, eventually occlude the blood vessel. It won't harm. It cause chest pain, reduce perfusion, and can cause heart failure also. Yeah, and that, yeah, but it won't kill the patient all of a sudden like that. By the case of acute coronary syndrome, because the plaque rupture here, you can see, and then promotes the clotting cascade within 10 minutes, either it closes partially the blood vessel or totally occlude the blood vessel. Totally occlude, yeah. Total occlusion cause STEMI, not total occlusion, unstable angina on STEMI, but the difference between unstable angina and non-STEMI, it depends on the speed of the blockage, the site, and also the degree of the block. Okay, next slide, please. Okay, so meaning that definition of unstable angina, again, the patient presents with chest pain. Both, actually, all the three present with chest pain. Yeah, unstable angina, normally the degree of chest pain is not too bad, sometimes 5 to 10 minutes, which occur all of the sudden. So how do you differentiate between stable angina and unstable angina? In the case of unstable angina, the chest pain occurs all of the sudden, all of the sudden. Yeah, suddenly the patient has chest pain. The patient actually was normal before, and then suddenly she presented with chest pain. And then or the chest pain, the patient has stable angina, for example, like meaning that the pain always constant. Then suddenly the chest pain, one day the chest pain become more and more internal frequency, increase internal frequency, increase internal intensity, increase internal duration. And those days, they say that if the chest pain occurs with this chest pain, actually labile chest pain occur within a month, and then we call it unstable angina. Less than more than 1 month, if the chest pain is constant more than 1 month, and it is called stable angina. Another thing is the chest pain after, for example, like post stenting, and then so post bypass surgery, and the first time chest pain also defined as unstable angina or non-STEMI. So stable angina, the chest pain is stable throughout, meaning the internal intensity, frequency, duration. Yeah, from those days, for example, like a month ago until today, the chest pain is the same. Then we call it stable angina. Stable angina caused by atrauma to acute coronary syndrome caused by plaque rupture or erosion or bleeding. Okay. Then how do you differentiate between stable angina and unstable angina or non-STEMI? So the differentiation is, number one, in stable angina, the chest pain is not that severe, not as severe as STEMI. Unstable angina, there's no ECG changes. In unstable angina, cardiac marker as troponin is normal. Non-STEMI, chest pain occurs suggestive or EMI, but the patient can present with unspecific chest pain, can be normal also, can has ST depression or inversion, yeah. But laboratory is showing release of troponin. This is very important, yeah, release of troponin. Whereas in the STEMI, the patient actually has chest pain. ECG shows ST elevation, some changes. Sometimes they call in the acute, in the early phase of STEMI, the patient sometimes present with upper hyperacute T wave, and then cardiac enzyme also will be elevated normally after 2 hours. Okay, next slide. Hello, next slide. So this is a pathophysiology of atrauma in which occurs in most of us actually after the age of 30, because we have this fatty laddens, yeah, within our blood vessel, eventually undergoing inflammation, or yeah, and then because of the epithelial injury, cause migration of monocyte and lipid eventually become a trauma. So the degree of this, the speed of this formation of a trauma, the degree of block actually is unknown, but it is probably most likely because of the lifestyle changes. If, for example, like if you are diabetic, you eat too much of fats, and then because of smoking also. Okay, this actually smoking and fat, of course, they cause the cap that cover the trauma is thin, which is prone to rupture. Okay, next slide. Okay, this is, for example, like we could solid In the stable angina, it's a plaque formation. So, yeah, when in the case of unstable angina, you can see here because the plaque, the plaque that cover the atherosclerosis atheroma is thin. And normally, not the thin one easily can get rupture. When they get rupture here, they promote the blood clots. And in case of stenoma, because the speed of the clotting mechanism is fast, and also the degree of the blockage is huge. And then this will cause ischemia, necrosis, some degree of necrosis to the myocardium, and then eventually liberated the cardiac enzyme. In this case of STEMI, it will be a complete occlusion. Okay, next slide. So again, I want to repeat again because of this one. This is, we call it stable, the unstable angina. ECG can be maybe ST depression kind of thing, or maybe it's normal. But the most important is does not increase the biochemical. If they increase biochemical, we call it non-STEMI. Okay. But in the case of, for example, the partial occluded vessel, again, we call it unstable angina, partial occlusion, and non-STEMI in the case of if the biochemical is increase, is elevated. Okay. In the case of STEMI, it will be total occlusion. This will again cause some change. You can see here as the elevation here. Some patient has, for example, ST depression. Yeah, then definitely this will, because of the myocardial injury, there will be raise in cardiac biomarkers. Next slide. This is again actually, after business or AMI, again, the presentation, the working diagnosis, you do the ECG, the biochemical marker, then you get the diagnosis. The problem, the most important, the presentation is typical chest pain. Normally the chest pain about 5 to 15 minutes. It depends on the degree of the block, it occur of the sudden. And if sometimes the block is huge, the patient can, the chest pain probably can be more than 30 minutes up to 15 minutes. Sometimes up to the 30 minutes in the case of ST elevation MRI. And then after that, you have to do ECG quickly within 10 minutes, you make a diagnosis. From there, it depends, in the presentation, you have to decide whether this is unstable angina, non-STEMI, or STEMI. Next slide. So in the case of how they differentiate, I already discussed with you about the stable angina and unstable angina. Both actually present with chest pain, but then the nature of chest pain is different. The stable angina, the chest pain is similar as before. Unstable angina, the chest pain actually occurs first time, more intense, more in terms of frequency, intensity, and also duration. And probably, for example, post PCI, the patient has chest pain. The patient sometimes occur at rest, not really as usual with the GTM. This is actually most students actually made many mistakes about relief by GTM. Sometimes they ask the patient to put the GTM under the tongue, and after the pain relief after 10 minutes. And actually, the pain after 10 minutes relief is not due to the GTM, because the GTM, when you put under the tongue, it should be relieved within 10 seconds. If relieved within 10 minutes, it means that the chest pain release spontaneously. Okay? Okay, student, understood?
Yes, Doctor.
Yeah. Then sudden increase frequency of the angina is also unstable, and also if the pain is duration of the chest pain is long, for example, like more than 20 minutes, most likely the patient unstable angina. So when you have the patient with acute unstable angina, or we call it acute kidney syndrome, you have to decide whether this patient is a case of unstable angina or non-STEMI or STEMI. How to differentiate? It depends on the ECG. ECG for unstable angina and stable angina is the same. It can be ST depression, but for the STEMI, it will be hyperacute tau T in the acute setting. And then in the first 2 hours, after 2 hours, then the patient can have ST elevation ECG. The biochemical marker also will be raised in the non-stemma and stemma. Okay? So far clear? Student,
Clear, Doctor.
are you clear?
Clear, Doctor.
Clear.
Yes, Doctor.
Okay, next slide, please. So the presentation again, okay, on acute kidney syndrome, the patient presents with chest pain. So then you have to describe, yeah, number one, the duration, the character, the nature. Normally, the chest pain occurs at the central chest pain, about 60% left-sided chest pain, about 5% on the right, sometimes at the epigastric area, yeah, sometimes also around the jaw. So the chest pain actually radiates. The chest pain radiates to the neck, to the jaw, to the teeth, and also to the left hand. Yeah, sometimes if the chest pain occurs in the epigastric area, yeah, it does not radiate to the hand because the epigastric area normally the lesion normally occurs at the right side, yeah, of right coronary artery. The left coronary artery normally present with the chest pain at the left sternum. Okay, because of the blockage, sometimes the patient has acute shortness of breath, hypotension, syncope, and then nausea or vomiting. So when you inspect the patient look a bit, you know, almost doom like kind, you know, pale, doom like feeling, yeah. Lung will be, for example, normal, can be in heart failure, yeah, yeah. And then it depends on the degree of the block and the timing when the patient actually come to you. Okay, next slide, please. So how do you evaluate diagnosis of stemma? In this case, you have to do definitely to have the ECG. So you must make a conclusion, a diagnosis within 10 minutes. Yeah, ECG might not be seen early on the stemma and need to perform serially every 15 minutes. But I don't advise to the serial ECG until you get the diagnosis. Yeah, the most important, you make a diagnosis within 10 minutes because you have to decide whether you want to do to go give lytic or not lytic. The difficulty is how to diagnose at the early part of stemma. You know why? Because at that time there's no ECG changes. Probably only the patient has faulty wave, and also another thing is cardiac biomarker at that time also negative. You know, because cardiac marker normally will be raised within after 2 hours from the onset of chest pain. So how do you diagnose? Sometimes you need echo. Then you see the echo when you see the akinetic movement of the myocardium, and then it is correlate very well to the ECG changes. For example, like your top with like here, then you see this MI, then probably you can initiate lytic therapy very fast because as you know, yeah, in the case of stemma, if you give lytic therapy within 1 hour, there will be 100% myocardial reversibility. So after 3 hours, then you are dealing with only 50 to 70% myocardial reversibility. So from this ECG evolution, you have to know this is normal, yeah. So when your patient come early, sometimes they have peak T like this, yeah. And then eventually it will evolve into ST elevation like that, yeah. This one and this one. Then after that, yeah, within 12 hours, you will see a Q wave. Q wave. Then this is after a week. Yeah, within a week, you get this T waves and slightly ST depression. But you can see here, you still can see here, this, yeah, the Q wave here, and then you can see the T inversion, meaning that the AMI occurs within a week. If, for example, like loss of T inversion with a Q wave here, normally the AMI already occurs after 1 or 2 weeks. Yeah, if no loss of T inversion here. Okay, and then to diagnose AMI also you need 2 contiguous ECG. I think you all know all the three clinical features of AMI. For example, like chest pain, ECG changes macro. You need 2 out of 3. From that, you know, the ECG, yeah, it must be 2 contiguously, meaning V1 close to V2 or V2 close to V3, or two with a 3 or 2 with the AVF kind of thing. Yeah, it means that it's too contagious. Meaning that if you do echo, the lesion is at the same side, meaning that V1 to V2, meaning that at that myocardium. It cannot be this myocardium and suddenly that myocardium. Then you cannot explain why the occlusion occur like that. So patchy. Yeah. Okay. Next slide. So before we proceed, actually, I will do a quick revision of the ECG. So this is normal ECG. From actually this ECG, the start from your AC node to the AB node here. There will be your P wave, yeah, P wave here, yeah. Then this is called your PR interval. Okay, and then after that, you can see here, especially when you see most of the normal ECG, you can see this initial like Q-like thing, yeah. The PR, this is here, see, up to Q-like wave here. But if you go to the ST, will be V1, in the V1, there shouldn't be any Q. You know why? Why a Q wave here? Because in the septum here, this the wave, the travel is like that, yeah, from left to right. Yeah, from right to left like that. So I think you know. So you put V1 here, so your V1 will be positive. So any Q in V1 is always pathological, even though it is small. Because in V1, because the wave that take away from the septum here, it coming from the right septum here to the right. So you put V1 will be positive. But the normal ECG normally there will be some small Q in small initial small Q followed by R and the S, and then this is the T wave. Okay. Next slide. This is QRS. Okay, next slide. So the P wave, I think you know, I don't want to describe it, present at depolarization as a duration is 0.06 to 0.12. Yeah. Okay. That will not precede the QRS, but the most important, it must be a look symmetrical like this. And it is said that it's the tall, the height is about 2 millimeter, the width about 0.08. I mean 2 boxes. Yeah, this is normal P wave. So any abnormal P waves, you should probably think of the source of atrial depolarization is not coming from the AC node. Okay, next slide. So then the PR interval, that's just now probably out from the conduction from the to the AB nodes. This here, to the AB node, then the duration is about 0.12 or to 0.20. Why this duration varies? It depends on the heart rate. If the heart rate is too fast, so the duration will be around 0.12 like that. Okay. Next slide. And then this is QRS complex, the Q, R, or the positives are the R, the negatives are the Q, then after the R is always the T wave. Yeah. So the present depolarization of the ventricle follow the interval, the duration 0.06. Yeah. So normally, yes, you will see the Q wave very small, and it is said that the Q wave is pathological when it is 25%. Yeah, of the R yeah, 25 R it is pathological, except in the V1 there shouldn't be any Q wave. Okay, next slide. So this is a normally the J point, actually the point mark at the end of the QRS. Actually, it is defined that the J point is where the S meet the T. Okay, the S meet the T, the beginning of the T. This is called S. This is you want to measure whether ST depression or not. We measure from the J point to the normal. Okay, then only we take whether it's ST elevation or ST depression, depend on the J point. Okay, this okay. Next slide. Again, the T wave represent the ventricular recovery or repolarization coming from the outer to the inner, and follows by S wave. S wave, it is depolarization. The Q and R is repolarization. If the S wave is broad, yeah, meaning that QRS is broad, it means that the conduction with the myocardium is not good. Yeah, that's why they have broad QRS complex, or probably it's coming from the we call aberrant pathway because of left bundle branch block or right bundle branch block, or maybe the muscle is hypertrophic. Next slide, please. I don't want to discuss, on the ECG because we had to really discuss with you, and then one day it was short about the ECG. You say this is again an important ECG finding. Can you see this is J point, and then any ST depression here from normal. So this is your baseline. See, the J point is there. It may be slightly, yeah. So this is your normal baseline, normal baseline. The J point is here, okay, where the S meet the T. Okay, this one, So this is how many millimeters. Then again here, your normal here, the J point is here. Then you can see how many millimeters. From here, there's no J point. J point is here and here, meaning that there's no ST depression. It's more of T inversion. Agree with me, student? Hello, student?
Yes.
Okay, sorry. Okay, next slide, please. Okay, this is how. This is how you put the ECG. So V1 is here on the right side. V2, V3, V4, V6. V6 before we want to see the lateral wall. V1 to V4 to V3 want to see the anterior wall. So here we want to see the right side. This is posterior wall. Sometimes we let's put this here. ECG V7, V8. Then you get the posterior wall ECG. Okay, next slide, please. How do you diagnose again? I think you know, lateral is ABR V1. The ABR inferior, this one. Then okay. Receptor, we call receptor infarction. If we want to be to the reciprocal meaning that if there is ST elevation, so the repulsion will be ST depression. It should be a mirror image between one to another, meaning the anterior, the reciprocal will be the posterior. Lateral, the reciprocal will be on the right side. So I mean the septal, if you're talking about septal, V1, V2 ECG, reciprocal none, anterior also none. Anteroseptal, V1, V2, V3, V4, none. Lateral, 1 AVF, V5, V6. This is the reciprocal to 3 AVF, anterolateral, 1 AVF, V3, V4, V5, V6. The reciprocal to 3 AVF, inferior to 3 AVF, reciprocal 1 AVF. And I think you can more or less memorize this. Next slide, please. Okay, now we go to the problems. So this ECG student, where is the problem? The patient presented with chest pain or colossal sudden, and then you did the ECG, it shows like this. So where is the problem, student? Hello? Hello? Student? Okay, you can see more or less faulty here. Probably in the V2, V6, when it's slightly tall. Next slide. Okay, because of the V2, you know the coronary artery. So the LAD is anterior. So the right side is on the right. And then you sometimes have to point the inferior, inferior to 3 AVF down. The lateral wall is here. This is lateral. V5, V6. So more on the circumflex, sometimes also your LAD, your diagonal. Okay.
Okay.
Okay. So what is the common management? Definitely with the chest pain in the acute syndrome, sometimes you give morphine 5 to 10%. If you give morphine, you have to give antiemetic, like metoclopramide, then Migran IV, you give oxygen to the patient, probably you give nitrate. You give aspirin 300%, 300 tube, and also by clopidogrel 300. But it depends on the letter. You want to later on you will see many other drugs other than clopidogrel, pasugrel, ticagrelol. It depends whether you want to do early intervention or not. Okay, next slide, please. So in the case of unstable angina and STEMI, you give low molecular weight, for example, like enoxaparin, You can give heparin. Those days I give heparin, enoxaparin, or fondaparinux. This one again, you load with the 300 copidogram, whether you're going to give beta blocker or not, or you give nitrate to relieve the chest pain. Next slide. So again, sometimes when you have a case of unstable angina, okay, or non-stemma, you have to score. Why? Because this unstable angina, or actually is clustered, is classified into 3 groups: high risk group, and then moderate risk group, low risk group. The high risk group, actually, you should do intervention early, yeah, required by American College of Cardiology. You should do intervention within 11 hours. In our setting, recommended by our CPG, the ECG must be done within the index admission, meaning that you have to do the angiogram within the admission. But sometimes in the case of, for example, like in the case of cardiogenic shock, you have to do immediate primary angiogram chorus, yeah, within 2 hours, or the BP, low BP, yeah, and poor ejection fraction, you have to do early. So that's why, some center they come up with this scoring. We call gray scoring. You can see here, predict 6-month mortality. This score actually depends on age, heart rate, systolic blood pressure, the kidney, where the patient CCF or not, cardiac arrest on admission, or elevated cardiac marker. Any elevation of cardiac marker, meaning that non-stemma is a case of high risk unstable angina. You must do angiogram within that in the admission. Other than gray score, we have TIMI score here. Yeah, risk of cardiac event within next 30 days. How they predict actually depend the age, known coronary artery disease, either the patient receives aspirin or not, severe angina, and ECG changes or elevated cardiac marker. So that's scoring there. 1, 2, 3. Okay, so that score. This one, H1 score to score like that. So is more than 4. It's a high risk score. Okay. Next slide. So in the case of STEMI, time is muscle, very important. If you can do as early as you can, if you can do intervention on the spot, that better. Yeah, for example, like, because why? The reversibility, like I said to you just now, yeah, within first 1 hour, the reversibility of myocardial damage will be 100%, but after 1 hour, there will be some degree of necrosis and then some degree of myocardial damage. Yeah. So remember, in the case of STEMI, time is muscle, very important. So don't delay. You have to make a diagnosis within 10 minutes. Then from that, you conclude whether you want to give lytics, or whether you want to go thrombolytic therapy, or you want to do primary percutaneous intervention. So what is primary percutaneous intervention? Meaning that you bring immediately the patient to the interventional leg, then you do angiogram straight away, and then probably you suck up all the blood clots, and then you relieve the occlusion. Okay, in the case of thrombolytic therapy, the thrombolytic, for example, streptokinase, those days I think you know about streptokinase coming from the streptococcus. It's very cheap, about 300 ringgit, but the problem is streptokinase can cause allergic reaction, and also streptokinase actually problem, you have to give infusion for 1 hour, and the streptokinase can cause low blood pressure. Another is combinant streptokinase, yeah, such as altiplase and tenetplase. The problem of altiplase is slightly expensive, about 2,000 ringgit. Tenetplase about 5,000 ringgit per dose. But the good thing about tenetplase, you get a bolus dose followed by aspirin, followed by heparin. But altiplase, again, you have to give for 1 hour infusion. So if you want to do thrombolytic therapy at the pre-sent hospital, for example, like you want to get in, like in Australia, they give thrombolytic therapy at the site. For example, like at the clinic kesihatan, then actually they bring the patient to the center equipped with percutaneous intervention. They give at the site. I think tenetplase is the best compared to altiplase, because altiplase still requires 1 hour infusion. And also you can give beta blocker to the patient, but From the Kasmara tire, beta blocker is not indicated if the patient has more than Kilik 1, meaning Kilik 2 and above. Please don't give beta blocker. And then also you can start the patient with AC beta, for example, like this. Next slide, please. Then after that long-term management, you do ECG monitoring, especially for the first 24 hours in the CCU. Then you give aspirin, again, just now 300 milligram, the clopidogrel again 3 milligram. This one, after you discharge the patient will be on aspirin, clopidogrel, beta blocker ACE, yeah? And then aspirin lifelong, clopidogrel for 1 hour, and the ACE and statin. And you have to modify the risk factor, okay? What is the risk factor? Actually, it's divided into 2 groups. It's modifiable or non-modifiable risk factor. Definitely non-modifiable risk factors such as age, male, sex, yeah? Male high risk than female, age, I am low risk than you. I'm joking, sorry. Okay, and then black actually is high risk compared to the whites, and the Chinese, I think, slightly better low risk than Malays and Indian, and then and the woman and better actually compared to the men. This is unmodifiable risk factor. But the modifiable risk factor, for example, like obesity, smoking, lack of exercise, diabetes, hypertension. Some patients here, for example, like diet kind of thing, yeah. Then this one you can modify. So so after discharge, when you want to discharge the patient, you should modify this risk factor actually advised to your patient. Another thing is about your lipids, your cholesterol, LDL level also, you can be modified by giving statin. Next. So the complication, I think, the very early, the death, cardiac shock, you can ask a question letter, heart failure, and then for 72 hours, myocardial rupture, thromboembolism, and the late is after 3 days, a vertical rupture, regurgitation, cardiac tamponade, Dressler syndrome. I think you should read all this, and thromboembolism. Next. So this is a case, we do a case study, 54-year-old man, gentleman present to AD with a chest pain next. ECG changes, ECG next. So 30 minutes, what will you ask the patient? Definitely you ask about the chest pain. This patient is having chest pain for 30 minutes, central location, crushing in nature, related to the jaw, and the score is about 10/10. The patient shortness of breath, look very pale, clammy, and sweating, and vomited twice. Passes through hypertension and hypercholesterol. The patient is known as diabetes and also asthma, and then high family history of acute myocardial infarction. Father died at the age of 50 due to the myocardial infarction, and then the patient has high risk behavior because he smoked about 40 cigarettes a day and drink a bottle of whiskey a week. And then she also practiced sedentary lifestyle because of the asthma. Okay, next slide, please. What are the risk factors? This patient is smoking, obesity, diet, lack of exercise. Again, I repeat to you, the cholesterol, hypertension, diabetes, age, gender, male, and family history. So next. So ECG changes, student. Do you pick up anything? Student? Oh, student.
ST elevation.
Where is the ST elevation?
2, 3
AVF.
Okay, what is the onset? When is the onset of chest pain? How many hours? Can you predict here? 2 hours, 4 hours? Do you see the reciprocal changes or not? B1 to B3, ST depression? Can you see?
Yes.
And then you can see the ST elevation to V4, V5. It's quite long, you know. This is dominant vessel normally. RCA with dominant vessel. Do you see the reciprocal changes at the L also? Do you see? Hello?
Yes, doctor.
Yeah, another thing you can predict the duration of the AMI. In this patient, it should be more than 4 hours. Why? Any clue? Student? There's a Q wave, yeah? First 4 hours, there shouldn't be any Q wave. Can you see Q wave here? Can you see?
Yeah.
Yeah, the Q wave, yeah? The Q wave already present. Actually, the chest pain is more than 4 hours already. So, okay, you have to decide whether to give it therapy or not. So this patient actually plan till after 4 hours, PCI is better than thrombolytic therapy. The first 3 hours, thrombolytic therapy is as good as primary percutaneous intervention, first 3 hours, yeah? After 3 hours, PCI is better than thrombolytic therapy. But remember, you must refer to the patient with PCI lah. If the patient does not have PCI capable, then give thrombolytic therapy. Okay? Student?
Okay, Doctor.
Understood?
Yes, understood, Doctor.
Okay.
Doctor.
Next slide. This patient actually, in this case, we know already from the ECG to 3FVF, actually on the right side, is here. So the lesion will be on the right coronary artery. Okay. Next slide. And then from here, you can see, I want to just to tell you, probably I will repeat again. This is FMC, first medical contact. So when the ambulance here get the first medical contact, they do the ECG changes in the ambulance. Then you can see the ECG, they make a diagnosis within less than 10 minutes. Then they see this ST elevation and I. Okay, if they want to refer to a center with PCR capable, meaning that this patient admitted to the site, yeah, at site, yeah. So you can call the hospital with the capable, the PCR capable. If you can arrive at the hospital less than 120 minutes, then they can offer you primary PCI. Provided they can do the primary PCI, they can open the blood vessel within the 10 minutes, meaning that you can 120 minutes, meaning that so the time that you from 120 minutes, meaning that to the balloon, meaning we already can open 120 minutes to the balloon. 90 minutes is the hospital time here, and then 30 minutes you can 120 minutes, meaning from the time you start the ambulance to the time that we already open the vessel, it is 120 minutes. Meaning that you call the hospital, quickly they open the lab. When you arrive the hospital, quickly they bring the patient to the theater and they open immediately the vessel. But if you cannot achieve the 120 minutes, then the hospital will actually come up with another strategy. They give thrombolytic therapy, and provided reperfusion should be given within less than 10 minutes. In the case of hospital with PCI capable, like in the UAE, we can do if the patient admitted to our ED, so we should make nowadays the recommendation is primary CPR strategy. We should open the blood vessel within 60 minutes, less than 60 minutes. Those days 90 minutes, nowadays is 60 minutes already. Is the guideline. Okay? Are you clear? Hello.
Yes, Doctor.
Yes, Doctor.
Okay, next slide, please. So this patient actually we opted for when we do the angiogram, opted for PCI. This is you can see the total occlusion. Sometimes we suck up the blood clots and remove and put a stent there. For example, lesion is here. Alhamdulillah, actually the patient is better, and then actually we managed to salvage the myocardium. This is the procedure more or less. Then we balloon sometimes, then we put a stent there. Next slide, please. Case number 2, and the case that patient into just now. For example, like if come to you, you want to give thrombolytic therapy, sometimes you have to do a diagnosis. For example, like you want to know how bad is the injury actually, and then you should do further test. For example, like cardiac marker. You did ECG just now. Then you can see the cardiac marker here. Myoglobin is not very specific. It is very general. CK also not very specific. LDH is not very specific. This one is will be increased in all muscle. CK, LDH, and myoglobin. CKMB and troponin T actually very specific to the myocardium. You can see here, for example, that here, normally it was peak here. Yeah, you can see here CKMB within half an hour, and then within 2 hours it already diminished. You can see here. Yeah, this is that's why if about half an hour you can do CKMB, you see elevated, then you can say this is some myocardial injury. In the case of troponin I, can see, or troponin T, you see here, troponin I, troponin T peak, yeah, close to 1 hour, but like that, and then after that it's a diminish, yeah, after up to 14 days. So that is it, yeah, yeah. The troponin will be present up to 14 days. In the case of troponin I, T is sometimes about 8 days kind of thing. So very important. For example, if the patient come too early, for example, like 15 minutes, 20 minutes, yeah, then you cannot, then there won't be any cardiac biomarker elevation. Okay, next slide. So if you think this patient is a case of non-STEMI or unstable angina, depend on the biochemical marker just now, then you can decide whether you want to get anacetrine or fondaparinux, yeah, and then you can give clopidogrel, beta blocker, and nitrate essential. There's no thrombolytic therapy or no primary peritoneal intervention, but in the case of high-risk unstable angina or non-STEMI, we do early percutaneous intervention. Okay. Next slide. This is another chest pain that I want you to see. This is more or less ST depression. You can get the J point is here, that the baseline is 2, definitely is ST depression. Agree with me, student? ST depression, right?
Yes.
Yes. Okay, next slide. Okay. Sometimes you can, if for example, like you have this kind of ECG, anteriorly, sometimes it may be due to posterior myocardial infarction. Then you can do posterior ECG in this case. Yeah, you look at the back, yeah, B7, B8, B9, and then you can see some ST elevation changes there. Okay, so next slide. So you look at the B1 to B3 where the any ST elevation. Next slide, see. So here, there's some degree observation. Yeah, posterior ECG. Okay, next slide. So even though the patient has ST depression just now, still can be posterior MI, you have to do posterior ECG. So this is when you do the angiogram, you see. Normally there will be a blood vessel along like this, you know, the blood vessel like this, yeah. This is a circumflex. From here to here, already 100% blocked. Then there wouldn't any direct flow to the blood vessel. Okay. So this is a this is a case of MI. Then you can see like this, nothing here, on just a stump. No direct flow to the blood vessel. Okay. Next slide. Again, what do you see here? Acute chest pain. So then, one ABL. You can see one ABL elevation.
Yes.
So what sort of AMI here? One ABL posterior. Yeah. Okay, come next slide. So sometimes you give a thrombolytic therapy to the patient, if you opt for the thrombolytic therapy, you do serial ECG, for example, like 30 minutes at 1 hour. The best actually you want to look at the 90 minutes. If the ECG shows resolution, meaning that the ST elevation is reduced in terms of the height of the ST elevation reduced by more than 50%, and clinically the patient is better, it means that the thrombolytic therapy is successful. Okay, student? You got what I said just now?
Yes, sir.
Yeah, so if you opted for the thrombolytic therapy, you have to assess whether your thrombolytic therapy is successful or not. How do you assess? You do ECG at 90 minutes. If the ST elevation decrease more than 50%, yeah, and the symptom of the patient is better in terms of BP, blood pressure, chest pain, then it is said that this patient, that you have a successful thrombolysis therapy. Okay. Next slide. Sometimes the patient can have atypical eloquent presentation, for example, like like in this patient, LBB. LBB is difficult for you to diagnose whether the patient has AMI or not. Sometimes the patient presents with the LBB, yeah, and then with the chest pain, you don't know whether this is LBB with myocardial infarction or not. Then this criteria actually can be used to improve the diagnosis accuracy of STEMI in LBB. This I want to tell you. Yeah, this you have to memorize this. Yeah, there's the correct Saragossa criteria to diagnose. That's just what I want to highlight to you. Sometimes not all patients will present with typical ECG changes, especially in the LBBD. You can't see any ST elevation. Okay, next slide. Another thing is isolated posterior MI, like just now, for example, like sometimes they have this ST depression more than 0.5 millimeter in the V1 to V3. Then you have to do the posterior chest lead, at the V7 like just now, V7 to V9, you can see the ST elevation because at the posterior, at posterior part of the heart. Another thing is maybe this indicate to you ST elevation in the AVR, probably not always true. It shows that probably the patient left main occlusion, the wide spread as horizontal ST depression, then or ST elevation in VR more than 1 millimeter, ST elevation in AVR and also in the V1, more than the V1. Next slide. Okay, sometimes the with chest pain, present with pulmonary edema. What happened to the patient here, student? As the AVR is high. Can you see AVR high?
Yes.
Yeah. AVR like this can be wrong lead. You have to check your lead before you see it is an up AVR. But this one estimation AVR, maybe the patient has occlusion in the left main. Yeah. If you don't do anything, this one the patient can die within 10 minutes, 10 to 20 minutes. Yeah. Okay. Next slide. Okay, this is echo. Sometimes it will help you. It should be tally, could be commensurate. Yeah, if you have the LAD territory that shows also akinetic movement of that particular area. Yeah, the LAD territory myocardial movement. Yeah, so it must be tally. Then only only echo will help you whether this patient has acute myocardial infarction or not. Next slide. So again, step to approach ECG in the ACS, appropriate clinical presentation. I recapitulate again. Then after that, you STE, contagious leak, you think of AMI, this in the contagious leak, and corresponding to the territory, and look for the reciprocal. Sometimes you can look for the duration on the also, in the presence of Q wave. Q wave more than 4 hours. Yeah, the step 3 look at the T wave, maybe tall T wave is early AMI. Then you look at the QRS complex, maybe the onset LBDB. Then you have to be careful with the chest pain, maybe the patient AMI, because you won't see any ST elevation in the case of LBDB. And then you also want to see the dynamic changes on ECG. For example, like if the patient present with you the unstable angina or non-STEMI, if the ECG is dynamic means sometimes ST depression 2 deep, 1 millimeter, 2 millimeters, and the normal. It means that the clot is labile. That's why the ECG is dynamic. That is very dangerous, and at any time the patient probably can have heart attack, acute myocardial infarction. That you have to probably has to bring the patient early to the lab to do angiogram. Next slide, please. Okay, this one I just recapitulate again. It's our first medical contact. It's very important for you to know. Refer hospital, emergency department, ambulance. Okay, next slide, please. So again, first medical contact. This again, I repeat the ECG just now. The slide just now. Very important for you if in the heart side. Yeah, just now in the you have a side. Very important for you to decide early, do ECG within 10 minutes. If it is MI, they need to decide whether they want to treat and give something over there, clopidogrel or aspirin. In Australia, they can give lipid therapy in the ambulance. Yeah. Here we don't have that facilities yet. Okay, then you have to decide whether you want to send the patient to the hospital capable PCI or whether you want to give thrombolytic therapy. It depends on the time. Time is very important. Okay, next slide. I think this is very important, the relationship of pre-hospital care and standby. You can see here. Yeah, it improve mortality by 17%. Next slide, please. Okay, next slide, next slide. So, okay. So you have to see oxygen. Okay. Saturation is more than and then percutaneous intervention before 3 hours. The success rate is the same, but the problem of lytic therapy is intracranial bleeding. That's why in the Europe, normally 100% they will do primary PCI regardless of 12 hours or up to 24 hours to do primary PCI. Okay, next slide. This again, the strategy you have to decide. Next slide. Okay. I think I repeat it again. Yeah. Antiplatelet therapy given the first medical contact, you can opt for just now. Sorry, I opted for ticagrelor if you decide to do percutaneous intervention. Yeah. Ticagrelor is like clopidogrel. Yeah. So they act on that pathway. Okay. Next slide. Next slide. Okay. This is all the evidence. Yeah. Clarity trial, you can add clopidogrel, Atlantic trial. Yeah, these are the trial. If you, for example, yeah, want to be a cardiologist, you have to remember all this trial. Next slide. Okay, all the evidence. I think I stop here. Any questions, student? Student? Any question? Anything that you are not clear? Hello? Can I hear you?
Yes, we can hear you.
Okay. Clear or not clear? Confused? Student?
Yes, yes, Doctor.
You clear?
Clear, Doctor.
Yes, me clear or not sure? Hello?
Clear and wait for the reading.
Huh? Any question? Uh-huh. Oh, okay, okay. Here the patient center, so because when you give a thrombolytic therapy, you divide it into two, yeah, two groups, yeah. One we call it unsuccessful thrombolytic therapy, right? The second one will be, we call it recurrent myocardial infarction. Initially it's successful, now recur back. You have two conditions, right? If, for example, that the patient has recurrent AMI, sometimes you can repeat thrombolytic therapy, which can cause bleeding. Or if unsuccessful thrombolytic therapy, you have to refer to a center because we will do the PCI within 12 hours, 12 to 24 hours, Okay, we still attend, okay? I think in Malaysia, even though, and I think you can reach the hospital with capable PCI within 12 hours, I think you can reach the hospital, right? Meaning that you have to refer to the hospital, which can do PCI within 12 to 24 hours. Okay. Hello? Okay. Question? Student? No question?
And doctor, I have a question.
Okay.
If the patient come to hospital within less than 30 minutes, and there will be no cardiac changes and ECG changes, right? So in this kind of patients, do we treat it as an unstable angina, and we do a ECG serial ECG 15 minutes until
Yeah, this is very important question. You have to balance between the myocardial survival. If you late in making diagnosis of STEMI, there was some degree of myocardial damage. It depends on the symptom. The patient is very severe chest pain. Then you do echo shows. You have to do echo shows akinetic. Then you treat the patient has EMI. This is the decision must be done by a specialist. Yeah, because you have to treat as EMI. In American call it a cardiologist sick. Yeah, if you are happen to be in the hospital with PCR capable, you can do angiogram straight away to see whether this is AMI or not. If you have CT angiogram, which can be done within 10 minutes, you can do CT angiogram to see the plaque burden. And then the issues whether if you are at a hospital with the PCR capable, whether you want to start thrombolytic therapy, the specialist should discuss with the patient about pro and con of giving the thrombolytic therapy. Actually, I have the slide about pro and con, the contraindication for thrombolytic therapy. Yeah, in this slide also actually, I can show to you kalau you want to see. And then if the patient agree for thrombolytic therapy, then you proceed with the thrombolytic therapy. If the patient disagree, then you treat as a unstable angina. Then you keep monitoring the patient. Okay. Everything is actually you have to discuss with the patient, the option, and if the patient requests to be transferred to another hospital, then you transfer the patient. Okay.
Okay, doctor. Thank you. Understood.
Okay. Okay. This is the output contraindication for therapy. Okay. Any questions, student? Are you comfortable to manage acute coronary syndrome, student? Hello?
Not yet, maybe.
Not yet. Why? Any reason? Aziz?
Because sometimes based on theory, we might have to confess, but experience-wise, is because confident
You are year 3 or year 5?
year 5.
Year 5, my goodness. You are going to be a doctor, you know.
Yes.
You have to clock, okay, clock, then chest pain, then you divide whether it is, what is the cause. Do ECG. Okay?
Okay, then.
Any question? If not, I will end the session here. You can read my slide actually with the contraindication for therapy. As you know, this one actually you can read, and then you can read my slide. I don't want to discuss this because this is just a template that you have to follow. Okay. Any question?
Doctor, we have question in the chat box. If the time to balloon is more than 120 minutes,
Then you cannot do. Yeah, you must opt for thrombolytic therapy. Opt for thrombolytic, given lytic, yeah. Hello.
Okay, doctor. Regardless if the onset of AMI is more than 3 hours, still thrombolytic therapy.
Yes. Because time is very important. The concept is to open the blood vessel. It's not the method, yeah. Then after that, if you have choices, then you definitely you go to the safer choices. Okay. Okay.
Okay, doctor.
Okay. Okay. Anything? Any question? Chat box. Okay. Here. Thank you. Thank you to everyone. Thank you. Okay. If no question, I end the talk here. Is that okay? Or you have question? Burning question? Last question? I like question, you know. Yeah, ada Anis. Do you have a question? Hello.
No question, Doctor, for now. But I believe if we have any question after this, we will reach you.
Okay. This one ada chat box. Prof. Thrombolytic prefer. Okay, then I already answered the question already. Okay. If no question, thank you very much. Actually, yeah, I'll get back to you again, Madam Chairman.
Okay. That's all for today's session. So thank you, Doctor, for a good enlightenment from you. So